Okay, it has worked now. So let's go. Let's go like. I think this morning somebody entered the chat. I don't know. I was monitoring that person. It's like, there are some people who hijack your network. I realized when I was monitoring the chat, it's like sometimes they will hijack your network and they will ask you to pay before they will hijack your whatever you are doing. Yeah, no, they can even write bad reviews. Okay, they can write bad reviews, and it will be yes. So unless you pay, they will never remove it. Yeah, that is how stupid the internet can be sometimes. So I thought maybe he's the one who has done that. Let's see how it goes. I'm sharing the link. We are far behind. Charlie, no be now. That is why I don't even want to create the new. We have over 2,000 people on the page. Yeah. And good afternoon, welcome back. Let me know if you can hear me. Let me know if you're on the page and you've not subscribed. Please do that. Okay. If you are on the page and you've not subscribed yet to the channels, please do that. Okay. If you're on the page and you've not subscribed, please do that. So, wherever you are watching me from, can you just send me a message on the chat box to know if you can hear me? If you can hear me, okay? Let me know if you can hear me, and share the link to your friends, your colleagues. Share the links to your friends, your colleagues. Okay, good. So yesterday we did a bit of movement and handling, okay, mobility. So today we shall continue with that. We shall continue. We did the 4-point gate, the 2-point, the 3-point. We got to the 3-point gating. Okay, 3-point gating. 3-point gate. 3-point gate. We did 3-point gates. Perfect. Let's start. Let me start sharing the screen so that we start. Perfect. You can be heard, please, please. Okay. Cool. We back again. Sharp, sharp. We had a little bit of technical challenges, but we solved it. So sorry for getting in late. Right. So yesterday we did a bit of so we did our crutches. We just a recap. Okay. We did our walker, okay, and we also did our cane. I told you the journey should start from the cane. If you know how to use the cane, you know how to use the cane because the principle is the same everywhere you go. Okay, so you know how to use the cane, you know how to use walker now, walker on a flat surface, and you know how to use the crutches. Okay, always the weight should be in your hands. Okay, and 2 to 3 finger breadths below your armpit. Okay, and the angle over here also. So I told you that the workers are there to help you, to help the weaker side. Okay, so always it goes in the opposite direction of the weaker limb. Okay, right. So we know the crutches. We did our gating system. Okay, so we did the 4-point gate. We did our 4-point gate. We did our 3-point, no, 2-point. Okay, we did our 2-point gating. So this one moves and the opposite goes. Then this one moves and this one goes. Okay. Then so this is the 2-point. Okay. Then we have the 3-point gate where we are starting today. So for the 3-point gate system, okay, we have two types. The 3-point gate, we have two types. Okay, if you come here, sorry, we have the 3-point gate. We have the swing through gating and the swing to gate. Swing through, okay, swinging through, then swing to gate, okay. Good. Everybody wish to get the swing through because the faster it helps you to move fast. Okay, yeah. So let's go and learn about them. Okay. The patient advances both crutches and then swings the lower body through. Okay. This requires considerable upper body strength, balancing, and coordination. Okay. So if you look at here, in the swing through gate, the crutches are moved. This one, this type. In the swing through gate, the crutches are moved forward toward forward together. So if you look at this image, let me get my pencil. I like to illustrate. If you see this image, concentrate on this image. First, all the two legs are down, the two crutches are down. This is the starting point. Okay. So you first move the crutches, both crutches, a little distance ahead of you. Okay. Then you swing, okay, to the lower extremities, these two legs standing, okay, are swing through the crutches like this. And they will not come, you will not put your leg or step your foot on the same level. You swing through just a little bit ahead, okay, of it's faster. It makes movement so fast, okay, quick. Right. Then we have the swing to gate. Swing to gate. So over here too, the swing to gate involves the swing to gate, these two guys. It involves forward movement of both crutches simultaneously. Okay. So you brought the crutches here. And the lower extremities swing to the crutches where, so this is the area you place the crutches. So these two legs, when you swing yourself, it is coming to this level. It is not moving ahead like the way we saw the swing through here. So that's it. This is just so where is the gating starting from? This is the starting point of the gating. If I move my crutches here and I move my legs to the exact point of where the crutches is, it means that I have gone back to gating. So we said that swing, you swing yourself to gate. But if I move ahead of my crutches, ahead of the crutches, it is swing through. Okay, yeah. So it's the same principles, no issues. Okay, perfect. So before you can do this, then you are somebody that you should have, especially abdominal strength or upper body strength. You should have a good balancing because yes, and you shouldn't have any problem with coordination. A patient who is confused, don't try to give this procedure for him to do. They will fall. Okay, right. So let's look at crutches with staircase moving up and down. It's the same as the cane. I told you that crutches is plenty canes that we have connected together. Okay, so the cane is the basics, the foundation. If you know the cane, the basis and the foundations of the cane, you know every other assistive device for mobility. Okay. So the same fundamental principles applies. We go to heaven, good guys and bad guys will go to hell. Okay. So when you are climbing the stairs or moving up the stairs, generally you always go with the strong sides. Forget about this. Sometimes they like using this English, big English to confuse us. Okay. So I told you that the good, the bad, and the good. That's it. You were once a good boy, then you did a bad thing, and what they forgave you, and you have become a good boy again. Simple. So that's it. Good, bad, good. That's it. So when you are going up, You are moving up. Okay. So the crutches is there to support the affected limb. Okay. Can I let the affected limb go before the crutches? No. The crutches must go and ensure stability before I bring the bad limb. Okay. Aha. So the crutch, when you are moving up the staircase, is I've forgotten my pre-technical skills. So if you are standing here with your legs, everything here, the crutches will move here first. Then the bad, you see, so that is your good, the crutches will come. Then you have your two legs at the back here. Ask yourself, always the bad is in the middle. Always the bad leg is in the middle. Okay, so the bad will come and join so that the crutches will help them. Okay, then it will be left with the good leg, then that one to join. Okay, so you do the same thing. Now let's go down. Okay, we are going down. We said that what bad guys, bad guys, what will do what will go to hell or they'll go down. Okay, perfect. So we have so many examples here for the good guys. We are going down. So when you are moving down, just like the way you did for the king, you place the crutches on the same side of the unaffected leg. Then you move the bad leg down with the king or the crutches first. The same principle. Okay. So the bad, then the good legs comes and join. Okay. So you see like this. So the good leg is behind, and these guys will follow. Okay. Yes. The same way here. So down, going down, bring the crutches down one step, like this. So this girl is they are standing together. Okay. Then step down with the leg that had the surgery. This guy went to do surgery. They are in the physiotherapy unit. When you go, you see all these staircase there. Then you move with what? The good leg. How does it? Simple. Okay. Right. We cannot do mobility without understanding the concept of weight bearing. NCLEX will not ask you all this type of weight bearing. But when you are doing your care plan, you should know the types that this patient is full weight bearing. This patient is non-weight bearing. This patient is only the tip or just the touch, the toe. They can weight bear, they can step on their foot, but only the toe, like this. The toes will touch. Okay, weight bearing. Then we have partial. Some people can step the affected limb, they can stand on the floor, okay, like this, but it will not be, they will not put more pressure of their upper extremity on that side of the limb. Okay, so it's called what? A prescribed portion of body weight may be placed through the affected extremity. Okay. Then we have the weight bearing as tolerated. This is PRN. Okay, as tolerated. Okay, so patient bears as much weight as can be comfortable. If they can't, fine. But if they can, cool. Okay. Then full weight bearing, you and I, full weight. You don't have any problem. You don't have any injury. You don't have any fracture. Okay. Yes. So this is weight bearing. Why is it that weight bearing or weight bearing as tolerated? When we say as tolerated, it means that within the patient's tolerance. Within the patient's tolerance. Okay. Yes. So if the patient cannot tolerate, don't force them because the care plan says no, you have to review your care plan. Okay. Then we cannot also not talk about mobility without thinking about what? Range of motion. A patient has been brought car accident, motor vehicle accident, bicycle accident, whatever. Somebody is walking and tripped and dislocated one of the limbs or the joints. Okay. Someone is back from theater for orthopedic surgery with a range of motion. Okay, range of motion. So range of motion, it is simply exercises that help to preserve the function of the joint. Okay, the muscles, how flexible is the joint, and are we getting good circulation, blood supply and venous return from that joint, and the total functionality, okay, or the functional ability of that joint, of that area, of that limb. Okay, so somebody is having what, the leg like this, the leg like this, has got a sprain here. Are we able to move this joint, let's say, to left or right, or to we call it the dorsiflexion and all those stuff? Okay. Yes. So we have different. This guy is having a problem on this side, so we will be moving the hand to see how good it is. So another one too is here. So many pictures, I've added them. Okay, see. So you sometimes the arms, you do like this or they do like this. Okay, plantar flexing and what, or the palmar flexing and all those stuffs. Okay, they have different. But we group them into two based on the assessment you do for the patient. Based on the assessment, you group when you are doing your care plan, range of motion. You say that Aunt Ayarga is having what, a passive range of motion in this limb, or active range of motion in this limb. Okay, or with active assistive. Okay, yes, good. So different range of motion exercise. See on the hip. Okay, see so many pictures added. Okay, range of motion, range of motion. When you go to physio, or when you go to the the gym, those instructors sometimes they help you to do it. Okay, now when we say somebody is having active range of motion, it means that the patient independently moves the joint, nobody, no assistance, no help. Okay, there are some people, they are able to move, but you have to give them a little bit of assistance. That is what we call the active assistance or the active help. So you help them, you give them a little push, okay? Yes, but they are able to move. But some too, range of motion, okay, perfect. Everything is intact, they do everything themselves. So if the patient can perform active range of motion safely, then encourage the patient to do it. We are not here to stop anybody's independence. Okay, independence is very necessary. So independence before unnecessary dependence, very important. Before you help someone, ask the person, can you also help yourself? So you help the level they have, then you also help. Okay, there are people who come with passive range of motion. This is the opposite of the active. You do everything for them. Okay, patient cannot do range of motion independently, so you do everything. Their joint mobility, flexion, flexion, extension. Okay, adduction, all those one. The functional alignment, you hold the limb and do everything. Okay, passive range of motion does not provide the same muscle strengthening benefit as active. Yes. Because if I am helping your joint to move, I'll do it majestically, slow. But if you are doing, you know how painful you are or whatever you are going through. So if you want to move it, so the one who is doing active range of motion will get more strength, okay, muscle strength than me, who is passive. Okay. So, what are the safety concerns here when we are doing range of motion? You should support the joint, very important, so that you don't dislocate it or tear some tendons there. Move slowly and use smooth movement, and avoid forcing the joint beyond normal range. and stop if significant pain or resistance occurs. Okay. Force the joint until range of motion is achieved is a trap. You are not there to achieve your target. You are there to assess. Okay. So don't stress yourself. Okay. Okay. Somebody has immobility. Immobility. A pregnant woman just came from CS, a cesarean section, back to the maternity unit. Okay. Yes. Immobile. Somebody has done a long surgery, 9 hours, 10 hours, 12 hours, 15 hours surgery, immobile, staying at one place. Okay. What are some of the physiological effects we will get on these patients? We take it system by system. Cardiovascular, this patient is at risk of venous stasis and thromboembolism risk or orthostatic hypotension. Respiratory system, there's going to be secretion, what? Secretion retention, atelectasis, and pneumonia. Okay. Musculoskeletal system, there's going to be muscle atrophy, weakness, contractures, and bone loss. Okay. And the gastrointestinal system, if you are somebody who doesn't like moving, walking, you are at risk of constipation and reduced gastric motility. Okay. In the bladder, urinary system, you are going to get urine stasis, urine stasis, and stone or infection risk in susceptible patients. Okay. The electrolyte, especially the calcium, will be crystallizing to form stones. Okay, and all this urea and all this. The skin, staying at one place for long, pressure injuries. Okay. Psychologically, you feel boredom, isolated, sleep disturbance, and loss of what? Independence. Very important. So, the risks of what? Immobility. Immobility has brought what? Deep vein thrombosis. Let's see how it is. So, this is both legs. Good. You see, this is one leg, this is another leg, deep vein thrombosis. Okay. So this is the normal leg. So if a patient comes to the hospital with what? Unilateral leg or leg pain. Okay, unilateral, not bilateral. Okay, or asymmetrical. They use the word asymmetrical. Asymmetrical. It means only one side. Okay, this is the right leg, this is the left leg. You see how this one is swollen. First, people use tape measure to measure the circumference, calf circumference. But nowadays, those things were just deceiving people. Somebody has cellulitis, you would think it's DVT, you go and give all these clotting medications. Okay, so now they use Doppler. So Doppler, the duplex, okay, to know whether there is a clot there or not. Okay, good. So somebody is having a lot of varicose veins here. Okay, swollen veins and all those ones. Okay, yes. Then you see a clot in someone's leg because of inactivity. Okay, because of staying at one place for long. Good. So immobility reduces the pumping action of the calf muscles. You see why people get DVT, the pumping action of the calf muscles. So this contributes to what? Instead of the veins to take blood to the heart, they will just hold the blood there. When blood does not move, it clots. Cut yourself and let the blood drop on the table. Give you some few minutes, it will clot. The same thing inside the body, if your blood is not moving, it will start clotting. That is why when somebody gets atrial fibrillation, that the blood is sitting in your atrium, it's not moving to the ventricles. They will what? Quickly give anticoagulants or heparin, these medications to blood thinners. Okay, yes. So prevention is very important. Early ambulation of our patients is key. leg exercising, prescribe anticoagulant medication. Okay, patients who come back from orthopedic surgery or patients who are admitted on the ward. Okay, when you most of the times in the morning we give them what heparin shot, heparin shot, maybe 5,000 units. Okay, nice one to prevent all those ones. Okay, yes. Sequential compression devices and socks and all those ones, and adequate hydration when appropriate. Please drink water. If your blood becomes thick, it will start clotting. Okay. Never massage any suspected DVT. You dislodge like this one. You if you want to massage, you are just breaking it into pieces like this. So some clamp will travel up and go to the lungs or the brain and cause pulmonary embolism or stroke. Okay, so never massage. Never massage any limb that has deep vein thrombosis. Okay, if you are suspecting it. Okay, so we are not supposed to massage. Never massage. Okay, good. Never, never, never massage. Possible. Okay, clot. Okay, never massage. Let's look at immobility on respiratory complications. Our major problem is what? Secretions pooling. This word, pooling. If you're somebody who always likes sleeping in bed, you don't like walking, okay, the fluid, okay, your respiratory muscles will also be relaxed. The respiratory muscles, they are not only there to help you to breathe in and out, they are also there to help you to cough up secretions, to bring secretions out, okay, to bring secretions out. So as you are exhaling, there are some tiny, 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 tiny secretions in it. Okay. Sometimes, if you are lucky, you cough out a big phlegm. That means that respiratory muscles. So, if you go to the neuro unit, patients who are having spinal injuries and through traumatic brain injuries, okay, cerebral injuries, we give them cough assistive devices. Okay, patient has come back from theater, incentive spirometer to help them breathe in, expand the lungs, and they also cough. You exercise the respiratory muscles. But if you lie down always and your breathing ability goes down, your chest expansion goes down, you begin to store, you begin to pile up secretions in you. Bacterials like wet medium, and they thrive very good there. Okay, so it's not really about atelectasis. Okay, it's not really about atelectasis, but the impaired gaseous exchange. You are holding carbon dioxide and all this is infection. I mean pneumonia. You can't lie. Okay, you will get it. So these are the things you should know. Okay. And how do we prevent this? Repositioning. That's why every 2 hours, patients, you reposition them. Okay. Yes. Then early ambulation is very important. You see the nurses telling the patient, go back to your bed, go back to your bed, go back to your bed. Okay. Now allow them to be walking around sometimes. Then you cough and deep breathing exercises. Then incentive spirometer when indicated. Okay. The same time, immobility can cause contractures in joints and all those ones. Okay. So contracture is a persistent shortening or tightening of tissues that limits joint movement. So there are a lot of tissues around the joints. Okay. Muscles. So common areas that you can easily get contractures is the hip, knees, ankles, no joint areas. Okay, yes. Another major problem with immobility is what? Foot drop. The foot has dropped. Okay, this is your foot. This foot, this foot. This one, it has two functions. It should be able, or like say four, it should be able to move to your left like this, or your right. That is the lateral. So left or right like this. Okay, that is one. The other two is to move up or down. Move up or down. Okay. If it moves up, we call it dorsiflexion. Okay. And if it moves down, we call it plantar flexion. Okay. Good. When do we say somebody has foot drop? Let's say there are some nerves that helps you to what? To move your leg or your foot up to dorsiflex it. When any of these nerves that gets damaged, sometimes through immobility, through injury, whatever. Okay, yes. You get a condition called foot drop. Your foot has dropped because that nerve supplying the ability to move up is torn or is destroyed. So you get foot drop. Okay. Yeah. So if you look at here, this is your foot at the neutral position. To be able to move it up is what dorsiflex. Okay. To move it down is what? The plantar flexing. Yes, people who get foot drop, their problem is not plantar flexing. Already, what will hold you up is torn. So your leg is already down. So plantar flexing is not a problem. They can go down or come back to normal, but they can't go up. That is foot drop. Okay. Yes. So what do you do? People have foot drop. There are sometimes when you have to support their legs, okay, with all these packs here. Okay. Yes. To make sure that see someone. Uh-huh. So all these assistive devices. Okay. Yes. You help. So proper plantar fleshing can contribute to contracture and foot drop problems. So, how do we prevent it? Proper leg alignment, range of motion exercises, appropriate splinting or orthosis when prescribed. Okay, then what? Mobility. Do not simply pile heavy burdens against the foot because you want all patients. You have patients, specific patients who are having these problems, so you help them to maintain their this thing. Okay. Now let's look at pressure injury. We are coming to a close gradually. Okay. So pressure injury. Everybody knows that if you stay at one place for a lot of pressure on your tissues, on the bones, ischemia, all those ones, last, you get what tissue injury or pressure sores. Okay. So it's a tissue perfusion problem. So pressure injuries, we know it, pressure areas, we know how to treat it. Then falls prevention, mobility. When you go to any unit or any home, once we are walking, okay, then there should be a fall one day. Okay, there should be a fall. So when you are praising your little child who is almost 1 years, okay, you are happy that they are walking. Remember, you should also be ready for falls. That is why we have the precautions or the preventions. Okay, which people are at risk of falls? People who are falling before, people who are weak generally, people who have gating instability, people who are confused, sedation, receive sedation medication, hypotension, and visual impairment. Okay, all this, and people who need urgent and frequent toileting, especially care home patients. They will ring buzzer now. Nobody is minding them. They will get up because the urgency is to, when your bladder is full, okay, there are a lot of pains that comes with it, so they will fall. Okay, if you are not careful, then people who with unfamiliar environment, they can fall. Okay. So how do we prevent it? The core bell should be within reach so that they will not get out of bed to go and walk, and especially these care home patients. Okay. Then their pathway they are going to use to the kitchen, to the dining room, their pathway, if from their bedroom to they are walking to the bathroom, okay, they are walking to the toilet, they are walking to the kitchen, they are walking to the conservatory. All those pathways should be clear, nothing. Adequate lighting is very important. Non-skid footwears or socks, okay, or socks is also important. Then appropriate assistive device. An assistive device will be closer to their bed, okay. Toileting assistance if needed. Then appropriate bed positioning. Low bed. People with high rates of fall, low bed, okay. Then individualized monitoring. A lot of people think that with falls patients, if I put all the four side of the bed, I am protecting the patient. No. If you put the four side up, you are doing what we call restraint. Okay. I don't know why they think that way, but this is the principle. If you put four side, putting all four side rails up, depending on the circumstance, not always, depending on the circumstance, function as what restraint. Okay, it may also increase injury risks if confused patients attempt to climb over the side rails. So more side rails does not mean you are causing more safety. No, it is not automatic like that. Aha. So that is why you assess them individually. Not every patient should have what. For me, like this, if you admit me in bed, I can walk, I can do everything. Then you put on all the four side rails. When we say four side rails, you see these modern beds. This is the bed, not the mattress. So there's the bed. The bed is divided into two: the head side and the lower side. Okay, this is the lower and this is the head. The head side has a head rail here. The top here is what we call the headboard. Remember, okay, the headboard. The head rail is here, and another head rail is here. Then this is the side. This is the lower. So this is the side rails. Okay, this is the lower rails, but both of them, when you combine them, is what we call the side of the bed rails. So we have the upper side and the lower side. Then we have the foot. So if I do both the head side, and I do the lower side, I am causing what we call restraint. You admitted Ayariga. Ayariga can walk. Ayariga likes walking, doing everything. He's fit. He's a bank manager. I mean, he's walking to talk. He's fine. He only came for observation. Then you put Ayariga in a bed with all four sides up. That is restraint. That is restraint. Okay. Yes. So now delegation. As a nurse, when do we delegate any of our assistants to go and help a patient to mobilize? Have they been trained in mobility, moving and handling, helping the patient to move and handling the patient when the patient is moving? You are holding a patient, you are helping the patient to move, patient is falling down. That healthcare assistant doesn't know how to go about with the handling of the falls process. Okay, so you are delegation. You delegating does not mean uh, you should not know the competency level of the person you are sending. Okay, yes. So you should delegate stable patient, previously assessed patient, and the care you are delegating should also be a routine care, and the patient should be easily predictable. A patient who get out of bed and within a short time will be having orthostatic hypotension should not be given to a healthcare assistant to take the patient to the bathroom. Okay, because you can't predict the future. You are not God. So ambulation transfers, range of motion, and repositioning. Okay, yes. So these are the things you should know. but the RN should assess the situation involving first ambulation after significant injury and illness, first ambulation after a patient has been admitted to the ward, new weakness, new dizziness, new neurological changes, confusion, uncertain weight bearing ability. Then RN should assess if you don't know the baseline. Yes. Significant clinical deterioration, the D. Good. So these are the things you should know. Okay. Yes. So a patient who is known, predictable, okay. A patient who is stable, and the tax we are going to do is a routine tax, should be given to what? Should be delegated. Okay, is delegable. Okay, a patient who is new, who is unstable, assessments required, RN should do. Okay, good. So suppose a patient had major surgery yesterday and is scheduled for first ambulation, RN go in and do. Okay, never delegate this patient. Good. So let me see if anybody has any question for me. Right. You can type your answers to the chat box.
You can type your answers to.
Okay. You can type your answers to the chat box. Okay. Good. So we've done all these assistive devices. Okay. The cane, the walker, using the cane sequence, the walker staircase, moving up, the canes and all those stuff. Moving down, crutches, okay, weight bearing, and their types, okay. Patient falling, we have done it. Those of you who have followed this journey till now, we have done. After a fall, what should be done? Okay, unilateral weakness. So these are the tricks. If you don't want to learn anything, when you take the slide, come to number 50. Number 50. Okay. It says master mobility memory table. Okay. So this is what you can even snap it and put it on your phone. So when you go to the ward, before you delegate a patient, you come here. What is the patient coming to do? Aha. That's a situation and the principle. Okay. Yes. So these are the things you should know. Let's try our hands on these few questions. A patient has left-sided weakness following a stroke. The nurse observed the patient using a cane. Which action requires correction? Shoot your answers. I'm waiting for your answers, guys. The patient has left-sided weakness following a stroke. The nurse observed the patient using a cane. Which action requires correction or intervention? Yes, yes. Don't be silent on the page. I want to see you type. Left-sided weakness. Let me see you type. Yes. Yeah, using a cane. Cane usage. Some are saying A. Some are saying D. Okay. Yes. A patient has a stroke. Left-sided. So this is our patient. Okay. This is the okay. This is the right side. And this is the left side. And the question says the patient has this left-sided weakness. Okay. You saw the nurse observed the patient using a cane. So this is a cane. which part will the patient put the cane that you, the nurse, you correct that? No, 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 no. You are not supposed to do it that way. Put it here, put it there. Uh-huh. Okay. Yes. For correction. For correction. Yes. So the answer is when you see the patient holding it in the left arm, okay, it should be on the right side so that it will protect the opposites. Okay. Good. Question number 2. A patient using crutches is going upstairs after sustaining a right ankle injury. A right ankle injury. Okay. That is non weight bearing. That is non weight bearing. Okay. I go again. A patient using crutches is moving upstairs after sustaining a right ankle injury that is known with which sequence demonstrates understanding. Okay, cool. Question number 2. Shoot and let's go. Yes, question number 2. We are going up with our crutches. Which sequence? Yes, right ankle. Okay, so the same our patient. Okay, this is our joint. So right ankle injury. Okay. Hey, sorry, ankle is this ankle. This ankle, not right knee, right ankle. Yes. Yes. Good. So it's going to be the left leg up first, crutches, then the right leg. Okay. Question number 3. A patient who has been on bed rest for 6 days stands for the first time and says, I'm going to faint. What should the nurse do first? Question number 3. A patient who has been on bed rest for 6 days. Okay. Answer, engage in whatever we are doing, please. Okay. It's for your own life. Me, I've written my English. I'm only helping. I need, I love it when people pass. Okay. I love it when people succeed. That is me. Okay. Yes. That is why even when I'm tired, I still want to teach. Even when I'm tired, I still want to teach. Okay. What should the nurse do first? 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 Okay. I'm going to faint. Good. So you protect the patient from falling and assist back to a safe position. Okay. Perfect. I think I have to start giving you people difficult questions that you crack your head. Okay. A patient is tomorrow is Wednesday. That's our quiz. We shall see. A patient is most appropriate for routine ambulation. Which patient is most appropriate for routine ambulation by trained assistive personnel? By trained assistive personnel. Okay. 3. Good. So, question number 4. Which patient is most appropriate for routine ambulation by trained assistive personnel? Okay, by trained assistive personnel. So, a patient experiencing by trained, okay, healthcare assistant. So, a patient experiencing new unilateral, no. A patient ambulating for the first time, no. So, all these things are out. The things you, when you see, just keep there. A patient stable who has worked with a worker several times and according to okay, so predictable. Patient who has become dizzy. Yeah, so C stands out. Okay, question number 5. Question number 5. Good. An immobile patient reports new unilateral calf pain. Immobile patient. Okay. Our subject is immobile. So the nurse observed warmth and swelling. Which action should the nurse avoid? Should the nurse avoid? Should the nurse avoid? This is an up question. Okay. Yes. 50. Question number 5. Which action should the nurse avoid? The nurse avoid. A says assessing the extremity. The nurse should definitely assess the extremity. Comparing the legs are appropriate. Then massaging the painful calf. Okay, so C stands out. Okay. Please, the nurse should avoid, do not the nurse should do. Avoid. This is the key word. Avoid. Okay. So, question number 6. Let's look at priority. Which patient should the nurse assess first? Today, I showed you how to do this. So, which patient should the nurse assess first? Yes. I'm watching your answers. Good. Yes. Perfect. So let's group them into twos. For those who, if you are new here, if today is your first time here, this is the simplest way to catch your your answers. Okay. Don't be in a rush to assess all the 4 at a go. No, it's a waste of time. Okay. Because English will give you only 2 minutes for one question. So, a stable, which patient should the nurse assess first? A stable patient requesting assistance walking to the bathroom. So, Amasa. Okay, this is a stable patient. Okay, between A and B, A stable patient requesting assistance walking to the bathroom. Then patient learning cane use, who asks which hand should I hold first. Okay, so between A and B, a stable patient requesting assistance walking to the bathroom, and patient learning cane use, who asks which hand. So just asking will not cause any problem. So if A and B was only the answer, I would have prioritized what? The A. Okay, the A. Because this one, if you don't assist, they might get up and fall. Okay. So when you get it like that, you cancel the B. Now you jump to C and D. Immobilized postoperative patient with sudden dyspnea and pleuritic chest pain. Sudden dyspnea. So this guy is having a massa problem. Okay. And patient requesting passive range of motion. So definitely the C will come above. Okay, now when you group them, group A 1 and group C 1. So between group A and C, which one will win? A stable patient requesting assistance walking to the bathroom, an immobilized patient, postoperative patient with sudden dyspnea and blah blah blah. So you know that C is the king. Okay, champion. Please, what does the acronym AMASA stands for? Okay, AMASA is this is my own way to prioritize. Sometimes they can give you physiology questions. You don't know how to prioritize. Okay, so AMASA is the A is what? Any patient with ABC problem. So we have the A, B, C, D, E. A, B, C, D, E. Airway, breathing, circulation, and blah, blah, blah. D, and exposure. Okay. Then the next question is what? Maslow's hierarchy of needs. So you should learn all the needs, physiological needs, because some of the questions, the answers, they will miss them. They will take a patient like this patient like this. See, this is an immobilized patient. Okay, with sudden dyspnea. So the dyspnea and the pleuritic chest, he's having this A problem, the airway problem, and he's also having a breathing problem. Okay, his problem is he has two problems. So at the same time, he's immobilized. So you have what? An unstable problem. So he has two of these. Okay. I'll find a way, we will find a day to do more master. Don't worry. Let's just focus on today's one. Okay. Yes. So the Maslow's hierarchy of needs. The A is what? The actual patient has an actual problem, or potential. Sorry. Yes. Then the S is the stable and unstable. Okay. Yeah. So I mean, we will go through the Amasa. Okay. Not a rush. If you can't get everything today, we will go through the Amasa. I'll you find one of the mornings, do Amasa, get scenario questions, and we solve it. Okay. Good. So when you see a mobility question, you should know this algorithm. Is the patient stable? The patient weight bearing? Are they weak? Are they using an assistive device? Okay. Is this the first, this patient's the first attempt? Okay. Is there dizziness or loss of balance? Can this be delegated or not? Okay. So these are the things you should know. So, I mean, these are formulas which I always add to it. When you get the slide, you go through NCLEX questions and how to move about it. Okay, champion. Now let's move to the part 4 of basic care and comfort. Part 4. So we are entering into nutrition, food and nutrition. food and nutrition. It's not every food that you can give to any patient. Okay. So safe feeding and swallowing techniques. Let me make it a little bit. Take this off. Okay. Good. Safe feeding and so patient. If you want to be a good nurse who feed patients, okay, these are some of the things you should do. The food they are eating, they should take small bites, okay, so that it will not choke them. They must sit upright at all meals. Sit up 30 minutes after eating and drinking. Okay, you can give them a puzzle, a book to be reading. So you see, when you go to the care homes, after they have their breakfast, their lunch, it's not immediately they finish, then we take them to bed. No, we allow them to sit there. Some of the care homes will buy television. Okay, they will be watching. The staff will be playing with them, talking with them, sitting. Yes, let them sit a while for the food to digest nicely. Okay, no feeding in bed or while lying. Okay, except some few patients. So some few patients, even with that, you need to set them up. Okay, yes. Then alternate sips of fluid with bite of what? Food. Sips, 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 sips. Okay. Yeah. So this is what the safe feeding round swallowing techniques. Okay, good. We have so many patients and the way they feed them. Some will have what tube feeding, parenteral, okay, enteral feeding. Sorry. So the peg tube is here, going straight to the stomach. You see where this is the stomach, and we create a hole through the abdominal lining or abdominal wall straight into the stomach. Okay, good. If the peg tube removes, this is just a small hole. If the peg tube removes, sometimes the abdominal wall can close this. uh So when peg tube removes, sometimes don't force it to push it through. If you push it through, it can be here. Where is my pencil? If you push it through this hole, this small hole, if you push the peg tube through, the tube can come and sit here. And when you have, there is a hole here. So when you feed, the hole will go into the stomach. But here is the case: you push through, and this ball and this tip is here. Okay. So when you feed, it will be dropping on the peritoneum. You are going to cause peritonitis over time. So when a patient's peg tube is out, cover with a gauze nicely. Okay, this hole. Arrange and take the patient to the hospital, the ER. They will fix it. Okay, because you don't have X-rays to know whether you are in the right direction or not. Okay, so NG tube, then the nasal and the orogastric tubes. Okay, good. So this is feeding. Good. Why is feeding a big problem for NCLEX and all the nursing boards? Because feeding helps the patient to eat. Can they eat by themselves? Yes or no? If no, who is going to feed them? Can they swallow well? Have they been assessed for swallowing difficulties and all those stuffs? Okay. So, so the mere fact that you are going to feed a patient food can turn into an airway problems, choking, swallowing problems. Sometimes the nurse is a new nurse, new graduate, doesn't know how to delegate. The nurse is coming from Africa. He's a very young girl, 22 years, okay, who has been employed to work in abroad. He doesn't know in Africa they are very respectful. I mean, you are not supposed to send your adults, but this young lady, 22 years, 21 years, who is an RN, is going to send a healthcare assistant who is 65 years old. Okay, so delegation becomes a problem for some of the African people. But the day you also become a healthcare assistant, they will finish you. You walk in. So tube placement problem, okay, fluid balancing and therapeutic diet. Okay. So what should this patient eat? The first question is not always what should the patient eat. Okay, it may be can the patient swallow safely? So the golden rule with feeding is that until the patient is able to swallow first, we can never feed the patient. How can you swallow first before I feed you? Okay. What does it mean? I have a bowl of food here and a little water here. Okay. Before I give you the food, you should be able to swallow a bit of this water. It didn't choke you, or I should give you a small bite. Take it. Before I feed you with everything on this plate. That is it. So you should do your swallowing test first before you feed the patient with all the bowl. Okay, good. So on that note, let's go to dysphagia. Dysphagia simply means swallowing difficulty. We can have dysphagia in so many patients: patient with stroke, patient with Parkinson, traumatic brain injury, okay, neuromuscular disorders, head and neck cancers, decreased consciousness, and advanced frailty. Why is dysphagia so a big like a big issue? Because food or liquid may enter the airway. When they enter the airway, the name has changed. It has become aspiration. Aspiration is airway obstruction or aspiration pneumonia. Okay, good. So, what are the signs of dysphagia? What are the signs? No patient. If you're having dysphagia, you can't hide it. Definitely, you show one of these signs. So, the nurse is the duty of the nurse to know all the signs. Okay, because not all patients will show all these signs before you know that. Some of them can show only one, choking, and leave and pass all the rest. It's still dysphagia. Some will show three or four and pass the rest. It's still dysphagia. So the nurse must know all. A patient who coughs when they are eating frequently. I give you one bite, you swallow, you cough. I give you another bite, you swallow, you cough, 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 cough. Three. Okay, I won't give you again. You did not pass swallowing test. There are some people who clears their throat after they've eaten. They choke. It chokes them a little, so they will choke a little before you give them water to push it down. Another one, it chokes them a little before they struggle, they swallow, or give them a little water to sip. No, we can't continue this game. You didn't qualify. A patient who gargles, gargling voice or wet voice. Forget about this English. I always love the wet voice. Yes. So, I mean, you're having choking issue. They pocket food in their cheek because they fear to swallow. People who have prolonged chewing, they chew in their mouth so many minutes. They don't want to swallow. It's fear, anxiety. Okay. Difficulty initiating swallowing and recurrent chest infections and unexplained fever after meals, not once on consecutive situations. Then oxygen, they desaturate right after eating. So all these ones are also there. Okay. Right. A patient may aspirate without choking. This is called silent aspiration. When do we see this? We see this especially in patients with what? Neurological problems, neuro problems. The food has climbed from the stomach to the airways, or whilst they were swallowing the food, instead of it to go through the esophagus, the food has what? Bypassed. Like it has gone to the airway. But patient is lying down calmly, quietly. Okay, They are not coughing. They are not coughing for you to know. They are not having any gargling voice. We call that one silent aspiration. No cough. So the fact that they did not cough does not mean they swallow safely. No. Okay. Yes. If you have a spinal cord injury, if there is a nerve that travels from the spine to your chest to help you to cough when you are choking, somebody has a cervical injury, one, okay, or a spinal cord injury, one, no impulse is coming here. So this nerve is not working. When you give this patient food and they are choking, would they be able to cough? No. Okay, but they are choking. You go and come back and you meet them, they have turned blue in bed and desaturated. Yes, we call it silent aspiration. People with neurological conditions. Okay, yes. So stroke patients, severe stroke patients. Okay, so a stroke patient and a meal tray. NCLEX will always ask you. A patient had a stroke this morning. A meal tray arrives. What should the nurse do? Okay, yes. What should the nurse do? So the nurse should assess for stroke patients. Always assess for swallowing safety before they eat. Okay. If not, don't automatically feed the patient because I know this woman. We go to church with her. Okay. No, this is one of the highest NCLEX principles in this session. Okay. Good. Safe feeding positioning. Okay, so we always or mostly advocate for what upright sitting for meals. Okay, yes, because when you sit upright, it helps food to go down, gravity assisted, bolus movement, and airway airway protection is also secured. Then there is a reduced reflux and climbing up, okay, and reduce aspiration. So upright positioning is very important. After you eat, what are you supposed to do? The nurse must ensure that the patient at risk of choke, at risk of aspiration, you are kept upright for a period of more 30 minutes and over. Okay, so you can engage them activities and all that. If you are activities coordinator, those who work in care home, we have activities coordinators. Okay, sometimes you can, or the nurse, if you are somebody who likes joking, you can joke, play with them. Okay, let them throw balls or throw this. Okay, get a puzzle. So when you go to care home, they have these books with plenty puzzles, word puzzle. You solve it, it takes their mind off. You can clock your 30 minutes, let the food digest, leave the stomach into the small intestine. Good. So then small bites, the feeding etiquette. Okay. Small bite and slow feeding. Don't rush food. Slow pacing. Watch them. Patient who is eating fast, 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 please take your time. Allow each swallow to finish. The healthcare assistants, there are some of the patients they will select this one. I don't want to feed. You can sit with the patient for 1 hour. They will never finish their plate. Okay. Allow them time to swallow. Okay. Avoid rushing, follow up prescribed food and consistencies like you are using the thickener. So we have the IDDS principle. Okay, dysphagia scoring. So the thickener, level 1, level 2, level 3, level 4. So you add those food. Then you check their mouth for pocketing. Very important. Do not give another spoonful while the patient is still trying to swallow the previous one. Very important. Then food pocketing. You should also check after a stroke. Majority of the stroke patients they will just hide it, especially tablet. Imagine you are going to give a patient, let's say, a pizza bun. That's the small tablet. And this patient hides it under the tongue or in the cheek. This patient is obolo. How will you know that this medication? You say, "Can I see your mouth?" Ah, then they'll open their mouth, forget it's in their pocket. Okay, so all these things you should check. The food they are hiding and all those stuff. Inspect the mouth and follow the patient's swallowing plan. Don't put your hand in patient's mouth; they will bite you. Okay, taking fluid. So this one I've spoken about it. The IDDS. I should have added pictures. I never saw this in Ghana, but I'm sure there's some there. But me, I didn't see. Okay, yes, there is a powder. You see, when a child is born, all this latogene and all this Cerelac, yes, those they are containers. When you come abroad there, especially UK, when I was in UK, you see a certain powder is very white, like the lactogens and all these milk powders. Yes, but it's not sugar. Oh. We call it thickener. We call it thickener. So after the nurse, you have done your assessment, swallowing assessment. Okay, or the nurse practitioner, whatever I've done, they will put the patient on what? Taking fluids if you're having swallowing difficulties. So the normal porridge we will give to Tommy. Tommy will buy in the morning and drink, okay, with nothing added. For you, if you are level one, we will put one scoop. You see, when you buy this children lactogen, you see they have some spoon in it, like this. It's like the scoop, like this inside it. So you fetch one. Level one is one, level two is two, three, three. So when I pour it in it, then I'll stir. It will make it thick. So you will never choke. You will never choke on it. Okay. Yeah, it helps you. Okay. Do not independently change liquid thickness based on only preferences. No. So if patient is on level one, and the time comes and they are still choking, okay, then you report and they will change them to level two or three or whatever, okay, or they change their diet plan. Good. The chin tack. You may see the chin tack maneuver in NCLEX preparations, but this should not be treated as a universal swallowing technique for every dysphagia patient. Certain compensatory techniques are what are prescribed based on the patient's swallowing evaluation. So always use the swallowing strategy recommended for the patient. You can't use for everyone. Okay, good. What if the patient coughs whilst eating? Okay, you stop the feeding, then you call the nurse to assess. But because we are nurses, we will assess. How about the healthcare assistant you have delegated? Will you delegate healthcare assistant to go and feed a stroke patient? That is another trouble. Okay, yes, but you delegated LPN to go and feed what? A patient, let's say demented patient and all those, and they are stable patients. Okay, then this is a new choking and all this garglet voice, and so they will come and report. When you send somebody, give the person instructions and tell them, if you see this, come and report to me. If you see this, come and report to me. So those things are there. Okay. Then we also look at what? Partial and complete obstruction, choking. It happens in children, adulthood, unless you die, it can happen to you. Okay. A patient who can cough forcefully. So this is the airway. An object can enter the airway like this, but it will not block all the airway. Okay. So person can exchange gases through this angle and go. Another person too, or the same patient too, there can be a situation where an object can enter here and block the whole airway. The air cannot go and come. So that is what we call the partial and complete obstructions. Okay, so a patient can cough forcefully or speak. Who can cough forcefully or speak may still have some air movements. Okay, so a patient with severe or complete obstruction may be unable to speak because the voice box is above here. Okay, so no air is coming out to pass through the voice box for you to get sound. Though your tongue is rolling la, 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 in the mouth, but the voice box, because of the obstruction here, total obstruction, you are not able to speak. Okay, you are in your room, your child is playing at the hall. You came back, the child will never hold the neck. The child is lying down, okay, unable to talk. You call unable to talk, he's turning blue, this suspect choking. Okay, you will not be able to cough effectively. You are coughing, but you can't cough effectively. Okay, you sometimes they make some little or no sound because the voice box is always sitting at the top here and the choking is below. Okay, patient will be cyanotic and they will, with time they will lose consciousness. If you call ambulance, look at where you are living or where your health facility is. What time will ambulance come? Okay, so this becomes an emergency airway problem, not a feeding problem. That's why NCLEX want us to learn, not because we want to write and pass NCLEX, but to help us, even in our homes, churches, everywhere. You need to be functional. Feeding a patient with unilateral weakness. A patient with stroke may have oral weakness. Depending on the prescribed swallowing plan, food placement may sometimes be directed to the stronger side of the mouth. Okay, yes, so that they can chew. So this is patient, this is the mouth. He has what left-sided weakness. This side is also weak. So sometimes you put the mouth food here, then they chew with this side of the teeth. Okay. But NCLEX expects you to prioritize the individual swallowing evaluation. This formula does not work for anyone, everyone. Okay. So that's why you need to do your individual assessment. Okay. Now, oral care in matters in what? Dysphagia. You went to see an unconscious patient, intubated patient, you work in ICU, okay? Or your grandfather, grandmother is in the house. They are sleeping, they are always in bed, and they have dysphagia problems, swallowing problems, okay? And you say in the morning, go and brush their teeth, go and do oral care. Good oral care is especially important for patients at risk for what? Because we have the microfluorides and all these things in the mouth. We need to take them away. The food we ate, the debris and all those that infection risks, we are reducing it. Okay, are you supposed to pour water into the mouth on unconscious patients? No, they might aspirate. Okay, entra feeding. So we have so many entra feed. Yeah. So the nasogastric, nasoenteric, gastrostomy tube, jejunostomy tube, ileostomy tubes, all those. Okay. The main principle here is if the GI tract works, but oral intake is unsafe or inadequate, enteral nutrition may be used. Person is having cancer of the throat, the throat, or cancer of the esophagus. He has a mouth, there is no cancer there. He has a stomach, there is no cancer. He has small intestines like this. Okay, why are you still forcing yourself to pass food through the mouth? Meanwhile, we have a peg tube here that you can go. Why are you forcing yourself to do NG tube? So all these things you should know. Okay, yes, good. NG tube. So, and this is a nasogastric tube. We pass through, the routine, the nose, the pharynx, the esophagus, and the stomach. Okay. So we use it for feeding, medication, decompression. and or drainage, depending on what the type of tube and what indication. Okay, not every NG tube is being used for feeding. Always check the purpose in the orders. Kring. You went to work, you saw your patient has what NG tube. Okay, those who work in message, you people have been going to your patient to patient, patient by bedside. It's good. That's the best practice. Bedside, you saw NG tube. Okay, you did not ask why did we pass this NG tube? What's the orders? What's the purpose? This NG tube was used to decompress, or a patient has taken what? A patient has swallowed poison. So let us pass NG tube to aspirate the poison. You went and lunch has come or breakfast has come, you went to pass cocoa porridge through it. Okay, you are not using the NG tube for the purpose. PEG tube is also there through the abdominal wall, straight into the stomach. PEG tube does not go anywhere. It's into the stomach. Okay, so PEG tube does not eliminate aspiration risk. The fact that this is your stomach and this is your abdominal wall, and I punctured it and I put a PEG tube here, and I'm feeding you through here, does not mean that the backflow to the esophagus is closed. If you don't position the patient well, if you don't maneuver the patient well, patient can, and if you overload the stomach full, if you overfeed them, they will aspirate. Water is always looking for what? Holes, channels to pass through. So they will aspirate and it will go into their lungs. Okay. Yes. So patient may still reflux, oral secretions, and all those stuffs. Okay. Head elevation in feeding is very good. It's a good concern in NCLES. So tube feeding and flat. Okay, you can't put the patient in the supine like this. Okay, at least their head must be up or sitting up like this. Okay, when you finish feeding, you leave them in that position for more than 30 minutes. Let the food go. Okay, then you bring them back. Some of the healthcare assistants, they will sit you up and feed you. After they are done, then they put you down. You see, sometimes you look at them and you smile. Oh, omo. Okay, after you finish feeding me, you put my bed down. What is going to happen? Aspiration risk, aspiration risk, aspiration risk. Healthcare assistants are not supposed to feed patients through PEG. This is advanced nursing procedure. So please note that. Verifying tube placement, especially NG tubes. So your stethoscope is very important. You can check the abdominal content for hydrochloric acid if there is aspirations. Okay, you can aspirate and check for hydrochloric acid. Okay, the litmus paper turning into blue and all those ones. All these are things that people do. Our stethoscope, you put it at the xiphoid process. Okay, the xiphoid, or yes, at the xiphoid process. Okay, at the so you see where the esophagus enters the stomach. This part, you put your stethoscope, the bell here, the diaphragm. Then you get a syringe connected to the NG tube. Okay, then you blow, like you push the plunger in. So that sound will make zoom. It will pass here. If the tip of the NG tube is in the airway, you will not hear it. Okay. The effective one is what? X-ray. You do X-ray. And in X-ray, the tip of the NG tube should not be here. It should be, if this is the stomach. The stomach is divided into three. We have the fundus, the body, and the pylorus. Always NG tube should be inside the body. Always the tip of the NG tube should be inside the body. okay, of the stomach, not at the pylorus, not at the yes, the fundus or the pylorus. Okay, yes, it should be here. So that's so X-ray will come and help you to know that. Okay, good. So I've explained all these ones, so you don't have to struggle yourself. Okay, yes, a classic outdated method. People will listen air over the stomach like this one, as auscultate and all. But nowadays, Charlie, if X-ray is there, why struggle yourself? Okay, good. After initial placement confirmation of the NG tube, the nurse monitor for possible migration or displacement according to possible. So how will you know? You place the NG tube, okay, then you take note of what the how many centimeters did you depress? Sometimes 60 centimeters, okay, 50 centimeters. You make that mark. Okay, you secure it nicely on the nostrils or whatever. You secure it. Good. Healthcare assistants or family members came, they went to tend the patient, and you came back, and the NG tube is now at what? 30 centimeters, this same level. This is the nose. Okay, this is the nose. So the NG tube is what? 30 centimeters. This is what? Accidental dislodgement. Okay, or we call it migration. The NG tube has migrated like an immigrant. Okay, aha. So all these ones will bring concerns of vomiting, respiratory distress if you are not careful. They are risk. It's not automatic, but they are high risk. Coughing, unexpected feeding intolerance, and all those ones. Stop using the tube when you detect this until placement is appropriately reassessed. Even if even if it moves to what 58, you left your tube at 60, you came, it's at 58. Only 2 centimeters difference. Please never use it. Okay, good. Now there are so many intra-feed methods to give to patients. Okay, we have continuous, connected to a machine, intermittent. So we feed you, we break for some hours, then we continue. Okay, then we have bolus, where you take your big cup, you take your your feeding bottles. Okay, you pour, okay, 500 mils, then you get your syringe, then your 50 cc, okay, you pour in it, then this is bolus. Okay, good. It depends on the location, the patient tolerance, aspiration risk, or when you are drawing your care plan, you take note of all these ones to help you. And then nutritional plan. Okay, good. Do not rapidly infuse a feeding or a feeder simply because the ordered volume must be completed, especially the night nurses. Yes. So if they order like say 1,200 mils per day for this patient with what? Neurological impairment, PEC tube, then during the day, this 1,002 mils, day staff will come. They said, we are taking the patient for a walk. Oh. 9 staff will start the feed at 6 a.m. Okay. Hoping that by 12 midnight, this 1,002 mils will be achieved, plus flashes. Flashes like say 300 mils flashes. Okay, or 200 mils flashes. Okay. The day staff will come. They will say, the patient relative came, we were taking the patient for outing, so we stopped the feed, or we were taking the patient to bathroom, we were taking patient to here, to patient's feed, and on the feeding pump, it will record the volume infused and the volume VTBI, volume to be infused. So volume infused, VI, and the volume to be infused. So volume infused is 300 since you set it up at 6 a.m. Let's say a patient relative came for the patient at 10 a.m. Okay. They took the patient out, brought the patient at 5 p.m. tea time. Okay. The morning nurses who are the healthcare assistants are doing their 2 hourly turns, 6 p.m. Okay. So they got here at 5:30 p.m. Okay. When they came, patient has poo. So they have to clean. They spend almost like 15 to 20 minutes in the room. Okay, time is now 5:50 or quarter 6 p.m. Okay. We have only 2 hours for morning staff to close. Okay, good. So they will start the feed. Sometimes the healthcare assistants will even forget. They stop the feed and they did their personal care. When they were done, instead of them to press continue, they forgot and left. The nurse too is not aware. Okay, so the night nurse will come and meet the feed at what? 300 the whole day. Then the night nurse, the night nurse will change the rate of the feed because 1,002 should go. You have up to 12 midnight for you to receive. Now it's 8 p.m. Night nurse has come. Night nurse came to work. He has 8 p.m. to 12 midnight, only 4 hours to infuse this 1,002. I mean, you have caused a lot of damage. So most patients with peg feed, all this entra feeding, they end up what? At the end of the month, let us weigh them. Those who work in care home, you can bear witness. At the end of monthly weigh, we went to weigh the patient. Patient has reduced drastically. Now we will now be worried. Let us call the nutritionist. The nutritionist order some food supplement, order this, order. It's because of these little things we do. Okay, this person forgot. This person came for this person. So if maybe those who manufacture the machines, they should they should add some reminders on it. So that so feed intolerance. A patient is taking, let's say, a feed with a lot of what? Roughages. All the feed you see, they are not the same one. Some with a lot of fiber, some with what? Low fiber. Okay. Yes, or zero fiber. Good. So you can be getting zero fiber for so many years. Then they will change your feed to low fiber. You realize that what the patient is vomiting, abdominal cramping, they will be having all these things. It's the feed that we changed. Sometimes too, the patient's feed has finished, but the patient must feed, and it is what weekends, and who is going to reorder for them to bring the feed to the care home or the feed those who are doing home care. So is the patient going to start from that Friday to Monday? No. Okay. So now let us pick somebody's feed and give to the patient. Intolerance. So you see, there are so many things that goes around with feeding a patient. Okay, with feeding a patient. They can get abdominal distension, nausea, vomiting, cramping, constipation, and aspirations. Okay, so the nurse should always assess the patient rather than simply increasing or continuing the feed blindly. You don't know all these tricks. Okay, yes. So we have the gastric residual volume. So do not memorize a single universal magic number and assume feeding must always be stopped at that number. No. Current practices vary by institution. Okay. So you should know the prescribed protocol, the trends, the symptoms of intolerance, aspiration risks, and abdominal assessment. Treat the patient, not just number. Okay. Every feed, when you're doing entra feeding, you have to flush the feed. You have to flush the tubes. Okay. So before you give the feed, you flush sometimes 50 mils in. Then you feed the patient. After you are done, 50. You, the human being, ask yourself within 24 hours, how many meals do you drink? Within 24 hours. If we ask you to drink 1,002 mils of of milk the whole 24 hours, will you be hungry or not? Okay. So if somebody, because of illness, they have prescribed 1,002, 1,005, 1,008, 2,000 mils, then you will also stop the feed and you will not give it to the patient. All because you forgot you did this, that you are not being fair to the patients. Okay. So feeding tube and also flashing, because you need to flash to prevent it from what blocking. So you flash, okay, to reduce clotting, maintain patency, and support medication administration. Okay, if you want to give medications through PEG tubes, entra tubes, okay, crash the medication. Is the medication the pharmaceutical company? Did they say we should crash this medication? Yes or no? Okay, so you speak to the doctor if they are concerns. So flashing is mostly before and after medication, or in between, or between incompatible medications. So sometimes we do when we are doing personal care. Okay, the nurse will be following. They will be giving flashes. They'll be giving flashes. Some of the nurses will tell the healthcare assistants, please, when you finish the health, personal care, please flash, give this patient 100 mils out. Flashes. Okay. Yes. So that is it. Medication. Do not automatically crash. Okay. We have entery coated medications. There are some medications we have put a coat around it to protect it from hydrochloric acid and gastric enzymes. If you go and crush it and you put it in somebody's stomach, they're going to be hazardous. It's going to be dangerous. So we have other hazardous medications and all those stuff. So the medication you are giving, what the manufacturer of that medication, what instructions were added to it. Crashing can alter drug absorption and produce toxicity or treatment failure. So don't rush to crash. Okay. Then, so in general, when medications are given through a tube, verify the medication, use appropriate formulation when available, administer medications individually rather than mixing all of them together. People will crash, put them in a small poly pocket and crash, click, 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 click. Okay. Then go and give. No, you give it one after the other. Then sometimes it depends on the number of patients. Okay. Yes. If a tube is clogged, a feeding tube is clogged. Let's say this is your stomach, this is the peg. Okay. This is the peg tube. It is blocked here because one person came to feed and forgot to flush it. So feed has blocked this place. What do we do? Do not insert objects into the tube. Some people will use some straw and all these things to push it. No. Do not use excessive force. Some people will be turning, winding it, okay, the tube, so that it will put pressure and push it in. Follow appropriate clogging methods and institutional. So when it clogs, and I was in UK, one of the units I was working, when it clogs, we just take them to hospital and they declog it for us. Okay, good. Right. You are feeding the patient enterally and the patient aspirated. Okay. Yes. And the patient aspirated. Okay. Or the patient is having signs of aspiration. Okay, these are the things they will definitely cause tachypnea and decrease, so you should know. Okay, so when they are doing all these things, exhibiting these signs, you should think about what possible aspiration, possible aspiration. Okay, the feeding should not simply continue while you watch and see. Assess the airway, respiration status, and intervene accordingly. Good. Now, parenteral nutrition. Parenteral nutrition bypasses the GI tract and delivers nutrients intravenously. Okay, so while the enteral nutrition will be using the the NG tube, all these ones, parenteral IV straight. Okay, good. The IV route. So Enkles will say when the GI tract is functional, enteral nutrition is generally preferred when clinically appropriate because it supports gut function and avoids some risks of central IV nutrition. Okay, so we have the TPN, total parenteral nutrition. TPN. I should have added a picture to this so that you know the TPN bag. Okay, TPN. When you eat, the food you eat, the banku, the bar, the whatever, the moi moi soup, and everything you eat, it has glucose in it, dextrose. It has amino acids. It has lipid fat. It has electrolytes. It has vitamins and trace elements. Okay. All these ones are in the food you are eating. When you give a PEG tube, NG tube, whatever, IJ, all these ones, it has all these, that feeding bottle you are holding, it has majority of these elements in it. Okay. Let us take that banku to the lab and extract or get this element out, add water to it, add our multivitamins that will change it, the color to yellow. Okay, yes, and give it IV to these patients. It means when I eat, this is the esophagus, when I eat and it gets into the stomach, before the stomach, the food will get into the IV, the vein, or the arteries. Okay. Before the food will get there, the liver will be here to remove the toxins, the chaff out of it. But here's the case, I am giving the food through the IV. So the food, all the, if there is a problem, if there is any infection, if there is any issues, if there is any reaction, sometimes the intestines, the small intestines protect us, but we don't know. If you eat, or the stomach, if you eat any food that the body does not, is not compatible with the body, you either vomit it out, or the microvilli in the small intestine will not allow the food to cross, will not allow it to cross. It will push it to the large intestine and you have diarrhea, running stomach. So food poisoning, vomiting or diarrhea. Okay, yes. But you have given food poisoning to somebody's IV. Okay. Is the stomach in the vein? Is the small intestine in the vein? So who is going to help it out? When is this food going to is being traveled to back to the heart as venous return? Then the heart will give it to the liver. By the time, some will even go to the head and go and cause problems in what? The brain. So that is one major issue with TP and total parenteral nutrition. A lot of patients have issues, okay, with those type of parenteral nutrition. Okay, good. So remember this element too. Because of their components, they can create potential or important risk. Example, infection, hyperglycemia, electrolyte imbalance, and fluid imbalance. And you should give it through what? Central lines. Those central lines will go to the big veins. Ah, big veins straight into the heart. Okay. So highly concentrated parenteral nutrition is typically given through central lines. Why? Because of what? High osmolarity. Osmolarity, not litio. Larity, okay, can irritate the small peripheral veins. They can collapse, they can destroy the veins. Okay, they can cause serious reaction in peripheral veins. So we always centralize big veins. Okay, but you can TPN. Yes, some people do connecting TPN to central line through the groin. I mean, infection is very high. Infection rate is high. Okay, yes, because patient will poo poo. We have to change. We have to turn. You have to. I mean, God. So do not treat a central line TPN infusion like an ordinary maintenance IV fluid like sodium chloride and normal. Okay, good. Now let's look at some precautions. Never and don't abruptly stop a TPN without a plan. Now, I went for night shift to this TPN has finished, so me, I did not continue. Okay. A patient receiving high dextrose parenteral nutrition can develop metabolic problems. If you stop it, they will get hypoglycemia sharp. The liver will digest all the sugar in the blood and they'll get hypoglycemia. Don't stop it too. You if an interruption occurs, follow prescribed protocol and assess blood glucose. It is one of their major problems. Hypoglycemia. So NCLEX will test you. Okay, NCLEX will test you. Good. So uh, so we have therapeutic diet instead NCLEX rarely test diets on just memorizations. No, instead it gives a disease and asks which meal selection is best. Which meal selection is best? I think I was having a slide on this. I'll look for it. If you take I'll look for it. Don't worry, I'll look for it. If you take the system by system and the type of food you should eat, okay, the type of the food orders, okay. So some of the patients and some of the nutrition orders we will be seeing, a patient will come that they will put the patient on low sodium diet, okay. One, because the patient, no sodium will retain fluids. Okay, so patients who are already retaining fluid, why are we also going to give sodium? So a patient with heart failure, hypertension, edema, renal failures, okay. High sodium foods often include processed milk, canned soups, every processed meal, canned products, snacks, crackers, and over here, crackers is biscuit. Okay. So chips, they call it chips, chips. Okay. Cured meats and many packed or packaged foods. They use salt to preserve it. Okay. So high sodium can promote water prevention and cause what? Increased circulatory volume or congestion. Okay. A person has come with what? Heart failure. Is it from the right-sided heart failure or the left-sided heart failure? Right-sided or left-sided? Okay. So either way, sodium restriction may be prescribed and fluid restriction may be ordered in selected cases. So daily weight becomes a very extreme importance. Okay. Daily weight is generally a more sensitive indicator of fluid. I told you about daily weight the other time. So don't go and write any weight in the system. The doctors, the physios, everybody looks at the night nurses' weight to prescribe their medication for the day to review. They review daily medications, daily plans, they review. So if you go and do any corporate chart weight there, you let them take the patient to dialysis. Meanwhile, the patient is not supposed to go, especially the patient with kidney failure. That yesterday the weight was 75. Okay, he's a dialysis patient. You came for night shift as a nurse, 6 a.m. or 5:30. Instead of you to weigh the patient, you went and wrote any weight, like say 84 kg. This physiologically means they are retaining a whole lot of water because weight is water. So any doctor who is coming for rounds in the morning assigned to this patient will order for her dialysis immediately or will order for her furosemide to drain this fluid. So you see the problem you have caused. Okay. So renal diet. A patient with renal failure will be placed on a fluid called what? Renal diet. Okay. What does the kidney do? The kidney is there to what? To drain the blood vessels that are moving. When they get here, the kidney will drain the fluid, okay, and will also drain electrolytes, okay. When it over drains and realizes that I have cheated the blood vessel, okay, when it gets here, it will reabsorb some, take some back, then circulatory volume and homeostasis is achieved. Okay, good. So a patient is having a problem where the kidneys are shutting down. So all the toxins, all the fluid are not moving out. They are retaining plenty toxins. Are you still going to, what do we have to do? Patient must eat. So let's put the patient on what? Renal diets. Depending on the stage of kidney disease, depending on the dialysis status, depending on the laboratory values of the BUE creatinine, the potassium, and the phosphates, okay, and the urine output. Okay, so what do we do? Sodium will surely be restricted because sodium will retain a lot of fluid in the body. Potassium, we don't want hyperkalemia is a big issue. Phosphate. Phosphorus is a big issue in kidney patients. Fluid retention and protein, the albumins and all those stuffs. Okay, yes. So what do we have to do? Do not assume every renal patient requires the exact same restriction. No. You consider the labs, the morning draws, and the renal function, the CBC and the BMP, the CMPs, and what? The BMPs. No, it's CMP. Then your treatment. That's it. Your treatment. Okay. Potassium rich food. When do we prescribe potassium food for a patient? Okay. When, let's say, hypokalemia, all these medical conditions that will waste potassium from the body. Okay. So bananas, oxygen, oranges, uh, potatoes, avocados, and all these ones. Okay. If the patient has significant hyperkalemia, this may be restricted according to the plan. Okay, because potassium has issues on what the cardiac conduction. Okay. A patient who is taking warfarin and vitamin K. Okay. So what goes on with it? Somebody is taking warfarin. Should we give vitamin K or not? The key concept is not necessarily to completely eliminate vitamin K foods. You assess the patient. Okay. Maintain a reasonable, consistent vitamin K intake. Large, unpredictable changes can alter anticoagulant or anticoagulation control. Okay, good. So, diabetics, let's go to the diabetic guys. What can we do to help them about their nutrition? We put them on diabetic diet. Okay. And diabetics, if you are controlled, if you are okay, they put you on what we call the ACHS. ACHS, meaning you check the blood glucose 3 times within the day and before bedtime. So 3 times within the day and before bedtime, you do one. So you do it 4 times within 24 hours. So we call it the ACHS. Okay. Yes, if you are stable, if you are okay, it's fine. Type 2 diabetes, type 1 diabetes who are stable, we just keep eyes on them. The ACHS, that's the blood glucose. And sometimes they can put them on Lantus and all those stuffs. Okay. How about their diet? You focus on what? Consistent carbohydrate management, blood glucose monitoring, medication timing, and recognize hypoglycemia. Type 1 diabetes who easily swing hyper and hypo. You want they are on insulin, let's say Lispro, rapid acting, Lispro. Okay, yes. What do we have to do? Before you give this insulin, the food should be on the table in front of the patient. Okay, otherwise they'll go into hypo. Okay, good. So I've already mentioned this one. Yeah. Do not give. So it says an awake patient can safely swallow and has hypoglycemia, may receive a rapidly absorb carbohydrates according to protocol. Okay, you can give them crackers. Some of them can tell if they are getting hypo. So some of them too, you meet them unconscious. So you should check your blood glucose. Any unconscious patient you see, blood glucose check. It is a protocol. Okay. Do not give oral food to unconscious patients or they will aspirate. So that's what you should know. Nail per os. When do we put a patient on nail per os? Gastric issues. Gastric issues. Okay. GI issues, vomiting, diarrhea, intestinal obstructions, all those ones. They are preparing for surgery. Okay. When we say nail per os, we don't assume that water is allowed or gum is allowed or oral medications are automatically allowed. Follow the specific order. Ask the doctor, what do you mean? Some people say nail per os and they will be giving the patient ice block to chew. Ice block is water. Okay, yes. So that is it. Nail per os and medications. There are some medications when patient is on nail per os, you ask the doctor, can I give or the some to you can patient with intestinal obstruction. You are planning to take the patient to theater. The patient said he is due for what? Gabapentin. So you have to crash and give through the NG tube. No. Okay. So all these ones you should ask the doctor before. Patients, when you come, you see that some patients are on clear liquid diet. Clear liquid diet typically includes liquid that leave minimal residue and are transparent at room temperature, such as broth, gelatin, clear juices, tea, coffee without milk. Okay, depending on others. So you see all these terminologies in your answer options. When you come here, it is something that people eat, drink, Okay, yes, we used to struggle a lot. Patient will ask you, can you give me some broth? Can you give me some gel? Some jellos? Uh, they are all in the fridge. It's stocked in the fridge for the patients. Some of the staff too will be eating some. It is normal in nursing. Okay, full liquid diet. So with this full liquid diet, you can be including what? Your milk. If I prepare a tea for you and I don't put as a tea, a Lipton or a coffee, and I don't put milk in it, it is a clear liquid diet. If I put milk in it, it's a full liquid diet. The puddings, the ice creams, the soup, cream soup, and all this one. Okay, they are full liquid diets. So especially milk. Milk is a full, it's liquid when you have not taken it. But when it gets into your stomach and it mixes with the hydrochloric acid, they become solid and they can stay in your stomach to 4 to 6 hours, sometimes 8 hours. Okay, before they move out. So this is full liquid. More nutrition. Okay. A lot of issues can put you into malnutrition, cancer, chronic illness, dysphagia, okay, poverty, no money, food insecurity, depression, cognitive impairment, yes, poor dentition, food, GI disease, prolonged hospitalization, yes. So for this one, the US government does a lot about it. Every state, every town you are, they have buses, vans that will come and share food to people. They can even give you some, take it home. They count how many number of people do you have in your house. They will give you a bag of onion, full bag, like the one that the